This is Dr. Shakil Ahmad. Today I want to discuss breast cysts. Breast cysts are common finding, may or not be symptomatic. The nodules, which are identified by the mammography, will be further evaluated by high resolution ultrasound and they may be characterized as cyst or solid. Characterization of the cyst plays an important role in the management. And cysts are classified as simple cyst, complex cyst, and complicated cysts, depending on the internal echogenicity. Simple cysts have the following characteristics. The first is anechoic center. Second, well circumscribed. The third, thin echogenic capsule. Fourth, enhanced through transmission or posterior acoustic enhancement. And then edge shadows or edge effect. The cyst virtually has no chance of malignancy. Simple cysts are avascular. The simple cysts do not need to be aspirated until causing discomfort or preventing mammographic compression and evaluation. Do not need short interval follow-ups. Malignancy inside simple cyst is virtually unknown. But one point which is much more important, that is, carcinoma can occur in immediate vicinity of cyst. So the tissue surrounding the cyst needs attention. This image shows circumscribed, thin-walled, anechoic mass with posterior enhancement and also refractive edge shadowing. So this is labeled as a simple cyst. The cysts that do not meet even one of the criteria of the simple cyst or non-simple and classified as a complex cyst. Majority of the non-simple cysts are designated as complicated and fall within the broad spectrum of the fibrocystic changes. However, the term complicated breast cyst does not carry the significance of complex cyst of kidney or liver. For the reasons, the majority of the non-simple breast cysts are not worrisome and do not need to be aspirated or biopsied. Important to understand that complicated cystic breast malignancies are extremely rare and usually have other features that are obviously malignant. Cysts with potential to be associated with malignancy are designated as complex cysts. Complex cysts demonstrates at least one of the following three findings: thick walls, thick septations, or mural nodules. With the improved resolution, a large percentage of breast cysts no longer appear simple. This is because they contain internal debris consistent with the fibrocystic changes. Internal content within cysts are part of the spectrum of fibrocystic changes and include the following: protein globes, cellular debris, cholesterol crystals, foam cells, and apocrine cells. Categorizing complicated and complex cysts into groups can help assess the risk of infection or neoplasm. Therefore, it is necessary to have a method of evaluating the relative risks of an individual complicated or complex cyst or two complicating factors, which are infection and malignancy. Cyst with low-level diffuse internal echoes should be evaluated for wall thickness and particle mobility. Acute inflammation or infection may cause uniform wall thickening. Cyst with thickened wall should be considered acutely inflamed and potentially infected, and it should be aspirated. Worrisome features include isoechic uniform thickening, hyperemia, and internal echoes, with or without fluid debris level. If the cyst with low level internal echoes does not have thickened wall, then the size of the internal particulate matter should be evaluated. Complicated cysts with diffuse low level internal echoes can contain either light subcellular particles or heavier cellular particles. Subcellular particles are merely part of the spectrum of the fibrocystic changes and are not worrisome. This image shows infected cyst. Here, uniform isoechic wall thickening and low-level internal echoes are present. And these are the features of inflamed cyst. The term complex cyst is reserved to describe a mass with both cystic and solid components. Worrisome findings are following: wall thickening of at least 0.5 millimeter, thick internal septations, intracystic nodule, mixed cystic and solid mass. Both the outer and internal wall should be scrutinized for suspicious imaging features. For example, angular margins, microlobulations, duct extension, or invasion of the cyst wall to assess the malignant potential of the lesion. Fluid debris level. Cysts with fluid debris level may also have a uniformly thickened wall, indicating acute inflammation. These cysts are often tender. Position of debris level within such complicated cysts will shift with changes in patient position, the same as GB sludge. When a fluid debris level is suspected, the cyst should be evaluated in the left lateral decubitus or upright position, as well as in the usual supine position. Complicated cysts with fluid debris level should be aspirated. In this image, the debris is shown here as white portion of the cyst. With the change of position, this debris will be shifted to the other side. So this is characteristic for the presence of the fluid debris level. The majority of thin septated cysts can be more precisely defined as clusters of simple cysts or as a large simple cyst with normal tissue indenting it. These do not need to be aspirated or even followed. They should be considered simple cysts. This sonogram is showing a cluster of cystically dilated ductules with thin intervening septations. Microcyst or macrocyst clusters are possible depending on the degree of the ductal dilatation. Complex cysts with thick septation should undergo further diagnostic evaluation. Aspiration alone is insufficient because the risk of false negative cytology is too high. In addition, should the cyst be aspirated in the cytology later found to be atypical or malignant, it may be difficult to find the lesion again for needle biopsy for needle localization unless the fluid reaccumulates. If aspiration is performed, one should be ready to follow the aspiration procedure immediately with large core needle biopsy. This picture shows the difference between the thin and thick septation within a cyst. This is the example of the thin septations, while this is this example of the thick septations. Eccentric wall thickening. The cyst capsule is important immediately adjacent to the eccentric wall thickening. Complex cysts containing papillomas or papillary carcinomas more frequently have irregular, angular outer margins and lack the smooth, thin, echogenic capsule. For the purposes of evaluating surface characteristics, the eccentric wall thickening is assumed to be a solid nodule within a cyst. As in solid nodules, the smooth, thin echogenic capsule indicates a non-infiltrating leading edge, which is more typical of benign lesion. The lack of thin capsule increases the likelihood of an infiltrating leading edge, and this is a sign of malignancy. In this image, eccentric wall thickening is demonstrated. This is the eccentric wall thickening with intact capsule, while in this image there is extension beyond the capsule wall. Thank you very much for watching this video. Hope the message is delivered.